Hi, my name's Jessica Farrow. I'm Group Head of Digital Communications and Insight at Halston Group. I'm joined by V today for our video series. We've recently released our MedTech white paper, which talks around the new realm of patient care, and we're kind of wanting to speak to innovators in that industry and people kind of working in that area to kind of get a bit of a greater understanding of what it really means to improve patient care and what MedTech can do to kind of improve their outcomes. I'll pass on to V to kind of introduce herself, what she does here at the NHS.
Okay, so hi, my name's Mapunde. I'm the Program Director for something called the National Institute of Health and Care Research Surgical MedTech Cooperative, which is a bit of a mouthful, but it tends to be shortened to Surgical MIC. So we are funded by the Department of Health and Social Care. The budgets are not the same as the NHS. The NHS gets its own pot of money. The NIHR gets its own pot of money. And what the NIHR does is it's the patient research equivalent. So NHS is patient care, we are patient research. So that's what we're funded to do. They do fund lots of other elements within the NHS, ranging from clinical trials, applied research, basic research, the full works. But our particular bit, the surgical MIC, we are funded to support any innovators to develop and evaluate their technologies, particularly for the NHS.
Yeah.
So our focus is on areas within the NHS that they do require sort of help in terms of new technologies for early detection of disease, technologies to assist with imaging, technologies that help with treatment, and also technologies that help people live with certain conditions. So our bit's obviously just within the surgery side of things. There are other bits like us that look at different clinical areas, but we pretty much focus on things called unmet clinical needs, and that is how we prioritize our work. So the unmet clinical needs is what the NHS wants technology to do, rather than companies pushing technologies onto the NHS.
Yeah, and we're going to go a little bit into that because I know you probably have a lot of medtechs reaching out to the NHS trying to get in there.
Yeah.
So what is, you say, sort of the core challenges maybe faced by the NHS, maybe specifically in your area, that need to sort of be addressed by medtechs?
So I think when it comes to surgery, what everybody is familiar with is waiting lists and the waiting times and just not being able to get the surgery when you need it. So there is obviously a space for technologies and innovations that address the waiting list side of things. But more importantly for surgeons and people within that particular area, waiting lists can also be helped by having technologies that can help them decide what the right treatment is for certain patients.
Yeah.
So sometimes surgery is done so that people can find out what is wrong with somebody. And then once you find out what's wrong or you figure out what's going on, then they might need another surgery a couple of months later to rectify it.
Right.
That is obviously not the ideal way of doing things, because the human body really doesn't like being cut open and being prodded about, and then you end up with post-operative complications. So you've got the waiting list and you've also got the post-operative complications where, the surgery might go really well, but then you might end up with side effects that then need to be managed, or some of them might not have remedies or therapies to help people live with them. So there's some people that end up with constant pain, for example, or people that have bowel surgery. There's a condition called post-operative ileus where your bowels actually stop working and basically everything just impacts in there. And worst case scenario is obviously it can sort of explode and it can actually be fatal. So, there's all these things that are the result of surgery is, if we can prevent patients having unnecessary surgery, then you minimize all those complications.
Yeah, and does that sort of come in that diagnostic sort of stage then?
Yeah, so it comes in the diagnostics, particularly for surgery. Diagnostics tends to be the imaging type. So we're seeing a lot of AI, artificial intelligence, badged things coming through. And I say badged because a lot of it actually isn't AI. It's just really pattern recognition. But I think for healthcare professionals in the NHS, what they want from AI is for it to be able to tell it, this is what's going on and this is what you need to do. Not just tell them, oh, this is what's going on, because they can figure that out from any other mechanism that they've got. You've got different imaging techniques as well. So some of it is about enhancing or further developing some imaging so it can be more useful in certain settings. So most of people hear terms like X-rays, MRI, PET scans, and all these things. They work for different things. It's not a catch-all kind of thing. If you're looking for something to do with tissue, then you get a specific imaging mode. If you're looking at bones, you're using something else. So what they want is, for imaging, is actually intraoperative imaging. So whilst they're operating on people, they want something that can actually enhance what they're seeing on the patient. Wow. And this is where things like augmented reality start to come in, and the immersive technologies where you can actually impose the patient's organ on top, and then you can see what you're doing, or you can highlight certain things.
Yeah. They're the ones that sort of, I know we're speaking to one of the companies that we're speaking to in the white paper, they sort of do that augmented reality, but it's absolutely insane what you can do these days, because it's not even just like a augmented reality of like a typical spine. It is literally that person's actual spine composition.
Exactly, it's that person on the table, and you can see. And I mean, one of the reasons it's also important is, when they operate. So at the moment, it's like when they're operating, let's say on the pancreas or the liver, there's all these things that are helping to position, because as the patient breathes in and out, the organs change position. Right. If you do something or move something slightly, everything changes position, and then you've got to start all over again. Which is why if you go in an MRI scan, they want you to lie absolutely still, because the minute you start shifting, everything changes within your body, and then they've got to reset all the parameters again. So where AR comes in is it can actually help with fixing a point in time, and that means they can rotate things and they can figure out this is definitely where we should be. Yeah. Because the blood vessels aren't always that visible.
It does ruin it out. Yeah. Luckily, haven't had to have surgery before, but like going for all this MedTech and stuff, I'm like, oh my God, I didn't realise that.
No, you realise, no, you don't have surgery for fun. It's not something people should take lightly.
No, definitely not. And we know that quite a lot of, obviously, MedTechs, there's lots of different solutions out there, and a lot of them do try to approach the NHS, particularly here in the UK, because it is the one to go to. There's not, too much on the private side at the moment. Yeah. But what is it that MedTech should really ensure they have before even trying to approach the NHS? I think some have come up against barriers, but it's because they've not really done prepared, I guess.
I think preparation is a key word there. I think so what we tend to see is you've got a lot of innovators. They're really good technologies. I'm not going to say these people have come with really poor technologies. People really have very good concepts. But I think the understanding of how things move and work in the NHS is very, very limited. Or sometimes people assume that it should work roughly in this way. I mean, the American model is very easy to understand because you've got private insurers and whatnot. Yeah. But the NHS model is completely different, because it's not a lot of people understand how, first of all, the money flows. And it's important to know how the money flows, because you can bring in a technology that's fit for purpose. But if the people who are responsible for paying you for that technology don't think that is the case, your technology just goes nowhere. So a lot of people have this thing that, we just need to go to the hospitals. The hospitals actually get paid to conduct surgeries. They're not just doing them out of their own budgets. There's someone who is paying the main secondary care centre to perform these surgeries, which is where the waiting lists come in, because someone's got to approve that, yes, the surgery is required on this person, so we need to do it. Yeah. So there's a whole lot of things in the NHS that work that way. Sometimes the person who holds the money sits within the primary care system. Mm-hmm. So you've got things like integrated care boards, which were the former clinical commissioning groups and former primary care trusts and all sorts of things. So I know they've had lots of names, but sometimes the money sits there. Sometimes the money sits within secondary care. Sometimes it sits within community. And I think as an innovator, it's very important to figure that out first. Mm-hmm. Is if you are looking at a particular condition, is you need to figure out what the pathways are. How do patients actually normally move through this pathway? And who is actually responsible for authorizing certain treatments and diagnostic tests and assessments? So that's one element of it, which is more common actually. And then the second element is because people are very passionate about what they've developed. Mm-hmm. It's their baby, they've come up with this, you've got all this IP, and you might have a patent for X, Y, Z. if it's not meeting a need in the NHS, they're not going to buy equipment just because it looks snazzy. It's got to have a patient benefit to it. And that's always a misconception when people think, oh no, the NHS needs technology. Yes, it does need the technology, but what is it doing? What is the impact?
Yeah.
If there's really no difference between this technology and something they're using in terms of patient outcomes, then why bother? Why bother with a switch? Why spend all that money? We're already comfortable with the arrangement that we have. Mm-hmm. And I think that's another common mistake that a lot of innovators make, is they want to push the technology onto the NHS instead of actually listening to the NHS to say, well, actually, what is it that is required? What do people actually need? So, I'll give an example with another post-operative condition. So patients, for example, that have cancer, colorectal cancer, they tend to cut out the portion of the bowel that's giving the problem, and then they sort of join it together. And it's sort of common in anything to do with tubes. So even some vascular surgery where they're dealing with veins and arteries, as long as you're joining two tubes together, there's always a risk that obviously they stitch them up, but there's no telling whether that stitch is going to hold, whether it's a weak one. So they have to stay in hospital and get monitored for a condition called an anastomotic leak, which is what it's known as. So if the leak starts to come out, they need a way to actually detect that this person, first of all, who's more susceptible to getting this condition. Right. And if they do, what do we need to do? What does it sound like? What does it look like? At the moment, we don't know all of those things. So from the NHS side, if you come in with a technology that's going to help with that, then that is what they're looking for. They're not looking for something that's just going to help with, oh, here's another imaging thing, and we've just used a different mode. It's like, well, how is it going to help us? So we're doing a lot of research, for instance, in this area where we're looking at different technologies for early detection of that anastomotic leak. Mm-hmm. Because once the contents start, especially if it's bowel contents, once they leak out, your bowel naturally has bacteria. The bacteria goes in the wrong place, end up with sepsis, and then you die. That's not what anybody wants after what should be a fairly routine operation, so to speak. So it's understanding the needs. I think innovators need to make time to find out what the NHS wants. It might not be what you want to hear, but that is what they will pay for.
Might not be the coolest, but
exactly. It might not be the coolest. Yeah, exactly.
But that's really interesting, and I think there's a point to be made, because you said obviously listen to what the NHS needs. Yeah. I think there's a point, do MedTechs, before they start going really down that production development of their actual product, do you think they should kind of reach out to sort of NHS members, clinicians, researchers, whoever, kind of get their feedback before they go too far?
That's what we always recommend, is once you've got the concept and you obviously have the freedom to share, if it's something that's got a patent, obviously get that bit out of the way. Mm-hmm. But once you've got sort of the sensitive bits out of the way, then definitely come and talk to people like us, talk to the NHS, talk to clinicians, and they will tell you exactly what matters. In some instances, it's also about the patient pathway, because you get companies that will come and they'll say, well, the NHS is paying £22,000 to use this device per person per year. I've got this device and it's only going to cost £500 per patient, so you've automatically got X amount of savings. It doesn't work that way. Cost savings in the NHS don't work on a simple mathematics level like that. You do need somebody who understands that, because from an NHS perspective, what they're looking at is, from the time you go to your GP, you're diagnosed with a certain condition, you receive the treatment and or surgery, and then you're discharged and then classed fit and healthy. That's it. Never see the inside of a secondary care hospital again. They're looking at the costs over that entire pathway. So how much are you saving over that pathway? So you might save £500 or £10,000 just on a surgery element, for example, but you might actually build up the pressure at other points. So you might actually increase the pressure upstream or downstream, which is then going to cause a lot of problems. So another example of that is, I can never remember the exact technology, but it was something to do with bowel cancer, early detection of bowel cancer. So everybody knows all the campaigns about, check to make sure that there is no blood in your poo when you go to the toilet and things. And then there was a whole campaign that, if you see that 3 times, definitely go to your GP and you need to request to be seen and get that monitored and checked. What that ended up doing was everybody went to their GP. You couldn't get a GP appointment because everybody was now worried that, oh, I think I've got bowel cancer and I need to have something called a colonoscopy, which is where they basically stick an imaging tube up your backside and they have a look at that. Now, the problem with that is if you eat rare beef that is rare, or you eat beetroot, that can show up as blood. Visually, it looks like blood. You've got no way of telling that apart. Even the machines have got no way of telling that apart to start off with. So if your diet is already high in things that could make your poo look like it's got blood in it,
Right.
then you're already worried about that. You've already raised your anxiety levels for particularly no reason. And I think the second element is that colonoscopy is not risk-free. Your bowels can be perforated. You can get all sorts of complications as well from that, which is why they try and sort of put people into risk categories to say who's got the higher risk. These are the people that need to be checked. These are the people that need to be prioritized. But that particular campaign led to everybody going to GPs. Now, if you genuinely had something a GP could help with, you now couldn't get an appointment because everyone thought that bowel cancer and everyone wants to get a colonoscopy, and there aren't enough endoscopists within the NHS to handle that kind of workload. So then it ends up building up everywhere, which is why people need to take the time out to understand how the money flows. If you understand how the money flows, then you know how the patient flows. And then start to get an understanding of what is my technology actually going to bring to this.
Yeah. No, it's so interesting. Like, it's just things that, like, from an outside perspective, I literally just wouldn't even cross my mind. But that's super interesting.
Yeah.
And this, you might have touched on this one slightly a little bit already. But what common mistakes do medtechs make when they're trying to sell to the NHS?
I mean, the common one is just not understanding the cost structure or the pricing structure of how that works. It's just literally going there. This is going to cost you. We've worked out that, this is your economic pinch point, and it's going to cost you £549 per patient. No, that's not how it works. All that costing information needed to have been done, or you needed to have an idea of it at the prototype stage. When you're doing the proof of concept, that's when you need to actually understand the pricing structure, because then you build the device or the technology that is fit for purpose for a particular costing structure.
Yeah.
The NHS has got different ways that it costs for different procedures and how it pays for hospital. You don't want something that's going to conflict with that. So it's understanding those things. I think it goes back to just not enough people understanding how that works. I mean, I don't blame them, because it can be very difficult to actually get hold of people who know this information. But that's why we say come to us really early on before you're like ready for marketing and all these things, because then you can still do the development work, but just not for the UK market. You can pick another market and then carry on with the development that way. But if you're going to do it for the NHS, you need to start right at the end to be able to come back at the beginning.
Yeah. No, it's interesting. I think one of the other points I had, so medtechs have like a lot of different cases to be made for one solution. There's economic, there's sustainability, there's patient care, there's like 4, 5, 6 elements. But do you think for, like, say if they're wanting to get in one particular trust, do you have to have like multiple champions sort of backing a solution to kind of get it through, or actually is there just really getting procurement on board?
I mean, it can be a bit of both. I think once again, it depends on the type of technology that you're looking at. If you're looking for something, if your technology is something that you think should be widespread, should be used by everybody, then the route of going through, finding out the costing structures and everything then will work well, because if you involve the guys at the higher level, they can actually then open the doors to everybody else. But if you're going to, if it's something that is being tested, or the concept has come from one hospital, then hospitals work in some ways differently. It might not work the same way in another hospital. So, we have a company, for example, that's got a technology to detect or to help patients prepare for surgery who've got aneurysms, and this is where your blood vessels are weakened, so they can burst at any time. So there is actually like a national campaign. So the NHS actually has, it's called triple A. I think it stands for abdominal aortic aneurysm. I might be completely wrong, but you might need to check that later. But it's called AAA, but basically it's NHS AAA screening.
Yeah.
So I think it mainly impacts on men over a certain age, so they are invited for screening in the same way that women are invited for breast cancer screening. But they've got to prepare. Once they're identified as high risk, then there's certain things they need to do to prepare. So they've developed a technology to help patients sort of prepare for that. But because they understood how the payment works, they were actually able to get the screening service to actually endorse that development, to say, well, actually, if you want to do things, this is where it needs to go, this is what you need to do. And once you get if the results are favorable enough and they make sense to us, then we're quite happy to help you to roll this out, which is the ultimate way to actually do it if you're a MedTech company.
Yeah.
If you want to get in the NHS, that's what you need, somebody like that on board. But I do understand that for some reasons, for some companies, they do go hospital by hospital. It's slower, it's more painful because you're doing things over and over again.
Yeah.
And they might keep asking for different sets of evidence that work with their particular setting. You know, so, yeah.
No, I've heard that from a couple of people because, like, I think sort of we're at a MedTech showcase event the other day, and it was, you know, I think a lot of them problem had with scalability, you know, getting it across them, because it's like, it's not starting again because you're on a DSL, but then it's sort of like there's an element to it because each one wants something slightly different to the solution. So there's like have to sort of adapt it and go through it again. But so I think if the favourable option would be try and go high level, but if not.
But sometimes it's a case of you've just picked the wrong clinical indication. So, you know, sometimes people come and it's like, well, I want to use this for, let's say, skin imaging on the skin. But we might tell them, well, the clinicians will tell them, this market's already crowded. Whatever you're trying to do here, no one's going to take notice because there's already 100 different technologies we can choose from. What makes yours stand out? So it's more difficult to gain traction when you're operating in a very competitive market. But what we sometimes do is, depending on the technology, it might be more useful in another clinical area. We might say, well, actually, you need to go to pediatrics because pediatrics would really love this because these are the problems that they face. It's obviously up to the company to decide that, but if they've already gone through the whole, we've got investors, you've got your pitch decks, and you've already committed down a certain route, it's going to be very painful and it's going to take a long time. But if you actually divert and gain traction in one particular area, you'll be able to come back to the skin because then you've built up a name somewhere else, and then people will start to associate that technology as, well, it's something we should try out in this area as well.
No, I think that's interesting because I think there's a point around just being adaptable.
Yeah.
Because I think, like you said, people like, it's my baby, it's my MedTech.
Exactly.
I don't want to change it, but actually just having that open-mindedness, I guess, to be able to adapt to what you actually want.
Exactly, because ultimately the NHS works on, it's got to sort out a problem, you know, whatever problem it is. And they also want to see proper results to say, as a result of using this technology, we have reduced X infections, or we've reduced these people coming back through A&E, we've reduced this amount. So that's so I think part of the problem as well is companies trying to not understanding what that evidence needs to look like and why that is important to the NHS.
Yeah, that's good. And I think, well, something with this white paper that we're quite proud of is Leeds. It's a little bit biased. So I was just wanted to add a quick little question in just to kind of understand, it's like, what do you think about the innovation happening here in Leeds and kind of what's your thoughts on it, really?
And I think Leeds is an exciting place to be at the moment in terms of innovation. I mean, there's lots of things going on, the university is a key part of that. The Leeds Teaching Hospitals is a key part of that. So there's a Leeds Innovation Hub, pop-up hub based at the Leeds General Infirmary. And this is a place actually for innovators. If you've already completed the development, it's a place where you can actually come, showcase your technology. And the nurses and doctors and whoever, when they come down from their lunch breaks or whatever, they can actually come and have a look and play around and they can talk to you. And that sort of removes the need for all these multiple meetings that take ages, to set up. I know there's the West Yorkshire Innovation Hub that's been set up as well together with the, I think, Leeds City Council and the Leeds Academic Health Partnership. and Huddersfield, I think University of Huddersfield have set something up. So I know they're not technically Leeds, but they fall under Leeds City region.
Yeah.
Just
bring
yeah,
them in.
exactly. Just bring everybody in. So there's a lot of exciting technologies, that are coming up, and particularly for surgery, Leeds is regarded literally as the home of surgery. So there's a lot of surgical things that happen. I know not really patient related, but this is where they operated on some tiger's paw. Well, they did a paw transplant actually. Poor tiger had lost his paw, and they basically transplanted it. So I know it's really not patient stuff, but I think it goes to demonstrate the skills and expertise that are in Leeds.
Yeah, definitely. I mean, I've never heard of that picture anywhere.
No, you should Google it somewhere. Tiger surgery Leeds. It should come up with the right thing.
That's what I'm doing in the car park. Good. But yeah, that definitely something we want to get across, because we are quite proud of just all the innovation that's being done here, and I do think it's quite just really wants to move forwards.
Yeah. No, I mean, we've got surgeons and academics who've also had their own technology, so they're very familiar with the MedTech development process as well. Which is why we're always so keen to help, give advice to people. Even if it's not surgery, we tend to give advice to them as well. And we're also doing our best to raise the next generation of surgeons with our MedTech Foundation, which is basically like the student arm of what we do. So anyone with an interest in MedTech basically can join this foundation. It started off just at the University of Leeds. I think there's now between 20 and 22 of these across different universities in the UK. So they basically spearhead sort of student innovations where they can develop their own concepts. And some of them are able to actually get investor funding actually for a couple of things that they do. They might not be as technical as you would expect, obviously, from a larger company, but it's just building that spirit of innovation so that it becomes normal to people to ask the right questions at the right time.
Just ingrain that early.
Exactly.
It's been amazing. Is there any sort of final piece of advice that you kind of give to Mentechs?
I think main piece of advice is manage your expectations. Things move at their own pace. In the NHS, it's not the United States. It's not the rest of Europe either. But take the time out to understand. Spend a lot of time understanding how the NHS works, how things work, and what actually makes things tick for the healthcare professionals you're targeting. And then it's up to you to make that decision to either continue down the path you're going or you choose a different path. I think that sooner you make the decision to kill a particular route, the better it is for everybody involved.
No, that's great. Thank you so much, B, for incredible insight. And there'll be a full series of MedTech related videos coming up on our website, so just stay tuned.